Hi, I'm Dr. John Bennett, broadcasting from sunny Miami, Florida in the afternoon. Today we have the pleasure of having Victor Volovici, MD, a well-known neurosurgical educator that works at Erasmus Medical Center in Europe. And he's also an advocate of microsurgery and super microsurgery. We have the pleasure also of having a couple neurosurgeons and students on the board. So first we'll go, before we turn it over to Victor, he's going to talk about Petrous bone cave of wonders, and I'm interested to find out what's behind that. But let's first go through introductions of the panel, and we'll start with Rakesh. Are you there, Rakesh? He may have stepped away. And Dr. Gauk, Peter, are you there now? We can introduce him later. Peter, you there?
Yeah, I'm here.
Yeah, could you please introduce yourself?
Oh, I'm Dr. Galkin Peter. I'm a neurosurgeon from Moscow. My scientific work was extraintracranial bypass for cerebral occlusive disease and for Moy disease. I made just a few minutes ago a presentation. Also, I allowed video at YouTube of my surgery. If you would have a minute, you can just walk through it, walk on it with your professional eyes.
Yeah, he was just. Slaven just mentioned that you were coming on, Victor, and Rakesh, you're back.
Yeah, hi. I'm Dr. Rakesh from India. I'm a neurosurgeon, and I'm eagerly waiting for a super micro surgery.
Very good. Welcome, Rakesh. Majed?
Yes, I am a medical student in the third year, Bucharest, Hello.
Welcome, and Slaven, please introduce yourself.
Hello, my name is Slaven. I'm a medical student from Croatia, and I'm very glad to be here. Looking forward to another great presentation from Victor. Thank you.
And actually, Slaven's the gentleman that introduced me to Victor when he gave a conference in Romania. Welcome, Victor. Could you please say a little bit about yourself before you come into you begin your presentation?
Yeah, sure. Hi, everyone. I'm Victor Volovici. I'm a neurosurgical resident in the Erasmus Rotterdam Medical Center. And my areas of interest are skull base and vascular, and especially neuroanatomy and microsurgical teaching. I've done a lot of research in microsurgery, and I'm trying to expand on that. And I've also done a lot of research in neuroanatomy in general, and now I'm trying to expand on that. And that's actually one of the topics of my talk today, because I thought at a brain tumor conference I should be talking about something which is relevant for brain tumors. So I'm going to be talking about skull base anatomy represented by the Petrous bone. So I think we should begin, and I'm going to try. Last time it didn't went so well. It went a little bit bad when I shared the screen. John, can you please tell me if you see the slides?
Yes, I do. It looks good. The Petrous bone and anatomical cave of wonders.
Right, and do you also see the second and third slides?
Yes.
All right. So okay, that's well. So I'm going to be talking about the Petrous bone. I call that the anatomical cave of wonders. It's a bit of a ripoff from Dolic, because he's always saying that the cavernous sinus is the anatomical jewel box. So if this cavernous sinus is the anatomical jewel box, because you have so many very interesting and important anatomical landmarks which are inside, then the Petrous bone would be an anatomical cave of wonders. And it's a cave of wonders because the amount of anatomical structure which you find inside is absolutely amazing. So it's really a wondrous cave, and it's really a privilege for people to be able to dissect and especially to operate in and around the Petrous bone. And I think the Petrous bone is also the pinnacle of skull-based surgery, because it really connects everything that's ENT, what we refer to normally as ENT, so inner ear, mastoid, but it also connects the infratemporal fossa and the middle skull base. So middle skull base is a bit of a nether region, because once you drill a little bit of the bone of the middle skull base, then you're already in ENT area. And if you drill even further, you might even get into oromaxillofacial area. So it's really a bit of a nether region. Where does neurosurgery stop and where does the rest begin? Well, I'm really, as you know, John, and I'm really a fan of people working together. But I also really believe that people should know what the others are doing and the anatomy of the other people. So if you're operating with the otologist, with the neuro-otologist, which is the specialist which operates in this area, then you should really know what he's coming across, what his anatomy is, and that you can communicate better once you're in surgery, that you understand each other and really can guide each other and not just, you know, draw lines. This is middle skull base, and from here it's otological area, and I don't really care what happens there because, you know, my only concern is to drill the petrous apex. So this presentation is really a roller coaster because it's a presentation with a lot of anatomy and a lot of complex things. And I do have to say that a little bit of knowledge beforehand would be nice, but I hope I can take you along in the journey in this cave and then come out the other side with a little bit more knowledge in this area. So this is the concept of the professor in Tours, an anatomy professor, which said, you know, if you want to know petrous bone, it has 5 areas, but if you really want to know petrous bone, then you should just, you know, learn to draw it like this and imagine, you know, squamosal part. This is the actual petrous part, and then the tympanic segment and mastoid. And once you put these all together, then you have really the petrous bone. It also has the zygoma here, and we're going to be talking a little bit about the root of zygoma. And then you can see here the mastoid and the external auditory canal. And if you look at it on, this is the lateral side, and if you look at the medial side, then you see the petrous bone. And this is actually where we're going to be concentrating our efforts, because you're usually going to do a craniotomy in order to remove this part to get to the brain, and then you get
sorry to interrupt. The slides are not moving. Slides are not moving.
All right.
So I'm sorry I missed that. I'm sorry I missed that.
All right. It's no problem. I'm going to do it like this.
Thank you, Rakesh. Thank you.
Yeah. Thanks. Thanks for pointing that out. So as I said, the lateral part and medial part. And medial part's actually the petrous bone, and medial part's actually the one I'm going to be concentrating my talk on, my lecture on. So medial part with the meatus in the middle, the apex, and the root to the posterior fossa with the sigmoid sulcus. And once you add the sphenoid bone, then you actually get to this very beautiful central area of the skull. If you look at it from underneath, then you see a couple of very important foramina, which we'll be talking about on the inside. But it's also important to know what the skull base looks like on the outside, because once you're drilling, you want to know with a sort of a 3D vision, as Albert Rotan would say, what you'd be coming across on the other side. So this is squamosal part again. This is the zygoma and the root. And you also see here foramen lacerum, the carotid passes above it, and the foramen ovale, which houses V3, the mandibular branch of the trigeminal, which is coming here in the infratemporal fossa. And if we look even further and we look inside the external auditory canal, then we can see the round and the oval window. The mastoid antrum is always deep to the spine of Henle, and that's really important because it's going to be showing us the position of the lateral semicircular canal. And you also have the promontory and the mandibular fossa because the mandible is coming inside here. If you look at it from the inside, then you see the sphenoid, temporal with the squamosal and the petrous part, and the clivus, which is all coming together in this area of the petrous apex, which is a very complex area, which is also one of the essential issues which we'll be talking about, because it's the way to go from the middle fossa to the posterior fossa, and it's also connecting the cavernous sinus to all the important structures of the posterior fossa, and all the important structures which are housed inside of the petrous bone. So this petrous part is a petroclival fissure. So this will probably tell you petroclival meningiomas. They're usually in this area. They can be bigger or smaller, but usually they require a certain amount of skull-based knowledge in order to, or a skull-based approach at least, in order to approach them. And usually, you know, I'm not going to insist on the choice of approaches because that's really another talk. But I want to lay down the foundation, the anatomical foundation, which will let you choose the right approach and then know where you're in order to let you drill properly and remove usually meningiomas or other pathologies, chordomas, clival, chondrosarcomas, or other pathologies in this area. So if we've opened the squamosal part has been removed. This is the petrous bone right here. Foramen ovale has already been drilled, and you see V3 inside the infratemporal fossa and also V2. And what you see between V2 and V3 is actually the Vidian nerve. I'm going to be talking a little bit more about the Vidian nerve in a minute. And what you want to do is, what you see here is the dura of the temporal bone has been peeled away from the middle fossa in order to get to the petrous ridge, which we're not seeing at this point, not yet. And there are a couple of really important landmarks here. The first very important landmark is, you see, this is the root of zygoma, and it usually points to the foramen spinosum. So once you know where root of zygoma is, then you can reliably identify foramen spinosum. That's really important because that gives you access to the middle meningeal artery, which is usually bleeding and which you have to stop or coagulate about 1 centimeter here. Once you have foramen spinosum, you know root of zygoma is here, and this is the temporomandibular joint. And if you look at the border of V3, so this is V3, the mandibular branch of the trigeminal nerve, and the maxillary branch of the mandibular nerve of the trigeminal nerve, which is going to foramen rotundum. So once you reliably identify these two, you know that if you drill in what's called the anterolateral triangle, then you're going to find the Vidian canal and the Vidian nerve. And if you drill this area here, this is called Glasscock's triangle, and it's above the greater superior petrosal nerve, which I'll be showing in a minute. And if you drill out this area, then you're going to uncover the petrous carotid. And that's really important. Here it is, petrous carotid. This is a temporomandibular joint, so this area has been drilled away in the posterolateral border of V3, and then you can uncover the eustachian tube, the tensor tympani. You have here foramen ovale, which is V3. Very soon after foramen ovale, it splits in the infratemporal fossa in all its branches, and then underneath the tensor tympani you find the petrous segment of the carotid, because the carotid is coming like this. It's going inside the carotid foramen, and then it's running as petrous carotid underneath V3 all the way to the petrolingual ligament, and then it becomes the cavernous carotid. These are all very important relationships, and I really think it's essential to know this and to do as much dissection and these sort of exercises in the lab as much as possible before you do a middle fossa approach, because this is all really essential key information. And if you drill further, then you see again the eustachian tube. So what do we do here? We actually decided, you can remove the temporomandibular joint in order to give you more access to the infratemporal fossa. And if you do that, then you come on the vaginal plate, and it's a vaginal plate which is obviously not gynecology. This is the vaginal plate of the medial pterygoid process, which articulates with the sphenoid bone and the palatine bone. And what you also see here, which is of utmost importance, is the tensor villi palatini muscle, which is inserting on the vaginal plate. And here, not very good, not very focused, but I'll show you in a minute. This is the styloid diaphragm. Styloid diaphragm is coming from the styloid process, which is here. And from the styloid process, you have three muscles which are going to nearby structures, the stylopharyngeus, the styloglossus, and the stylohyoid. And what you can do is, once you've seen and I reliably identified the tensor veli palatini and the styloid diaphragm with its 3 muscles, you can remove them. This is the tensor veli palatini cut. And then you can see here the carotid, which is coming from its cervical portion inside the carotid canal. And then it makes a genu, and it continues further as the petrous carotid. These are really important relationships to remember, because once you've identified the root of zygoma and you've identified foramen spinosum, then you should know in your head where all of this is. If we're to continue, we're going to look at first at the petrous bone from medial, and then we're going to be looking a little bit from posterior, and then we're going to be talking about the combined petrosal approach, which is an approach particular to Professor Fukushima, which is one of my heroes in skull-based surgery, but it's also one proper to Professor Al-Nefti. That's really an approach which is for really advanced skull-based surgery with a really limited indications. But it's really a sight to wonder once you actually see one in all its majesty. So if we're looking again from the medial side, you see here the trigeminal impression where the ganglion of Gasser rests, the arcuate eminence, which shows you always reliably the position of the superior semicircular canal. See the subarcuate fossa, which houses the subarcuate artery, the porus of the internal acoustic meatus, which runs, and this is actually very important, because if you're trying to uncover the internal acoustic meatus from the middle fossa, and you're going to be drilling this part here, I can remember my first dissections when I would be drilling here, and I'd always end up in the vestibule or opening the cochlea. Because what you have to realize is if you're drilling from the middle fossa, the internal acoustic meatus runs a little bit about 30 degrees posterolaterally. So it's not really a perpendicular canal as one would normally expect when drilling. So you shouldn't really drill like this. You should drill at about 30-degree angle in order to uncover it properly from the middle fossa. And this is the endolymphatic duct, which houses the endolymphatic sac. And if you look at this with the dura intact and with the nerves, then you see the 8th, the 6th running to the Dorelis canal, 5th running into Meckel's cave, and running inside the Gasserian ganglion. And then what you also see here is the arcuate eminence. As I said, it houses the upside of the superior semicircular canal. And once you drill here in this area, then you can uncover all the canals. And if you look even lower, then you can uncover the jugular foramen with 9, 10, and 11. 9 is always separated from 10 and 11 by this fiber string, so you can always reliably identify it. This area underneath the labyrinth is very important, because this houses the jugular bulb, and you can see it very menacingly looking at us in all its blue glory. And if you want to look at just the bony side of the internal acoustic meatus, then you see that this is the porus. The porus is in the posterior fossa, and inside the petrous bone itself, deep inside the heart of it, as you can see, once again, it's about a 30-degree this way. It's not just perpendicular to the squamosal part. If we look inside, we see a transverse crest and a vertical crest, which separates the fundus of the meatus into 4 parts. The facial canal, where the facial nerve runs, the superior and inferior vestibular areas, and the cochlear areas. The cochlear area is actually it houses a couple of 20 or maybe 18 up to 35 very small points, which are actually the fine branches of the cochlear nerve coming here. The cochlear nerve does not run as a whole to the cochlea, it just splits here in many tiny branches. So if you are pulling on it too hard intraoperatively, then you risk damaging it inside the meatus if you've opened it. If you haven't opened it in surgery, it usually is stuck to the dura, which covers this entire thing. But if you've opened it and it's a bit exposed, then there's always a risk if you pull here too hard. What you also see is that the inferior vestibular nerve also has a singular foramen for the singular nerve. And the superior vestibular area is much larger than the inferior vestibular area, because the superior vestibular area goes to the superior and lateral semicircular canal, so it has a little bit more ground to cover. And if you also let the nerves and the endolymphatic sac and the dura intact, then you'll see the facial nerve running to the facial canal at the end, and the superior vestibular and the inferior vestibular. Superior vestibular usually gives the utricular nerve, because the superior vestibular is running to the utricle. And the inferior vestibular nerve gives a singular nerve, but also a saccular nerve, because it runs to the sacrum. Also here you see this one, the cochlear nerve, which is running here to the cochlea area at the fundus of the meatus. If we're also going to add the other structures which are in the middle fossa, then you're going to see that we can also add the superior petrosal sinus, which is running in a groove here above the tentorium. Fifth nerve, seventh nerve, Petrous carotid. I've shown you the carotid from lateral when it comes inside the carotid foramen and then runs as the Petrous carotid all the way to the petrolingual ligament and the abducens nerve running inside the Relus canal here. But if you look at the fundus of the meatus again, and then you can really see eighth running inside the vestibule, and the cochlear nerve running inside the cochlea. This is a very beautiful dissection by Professor Rotta. And at the fundus, you can also drill inside the vestibule, which I will show you later. And what you should remember about the labyrinth, which is situated posteriorly to the cochlea, is that it has three semicircular canals, superior, lateral, and posterior, and some of these have ampulated and some of these have unampulated ends. So one of them is always ampulated and one isn't. And this is really beautifully illustrated here by Professor Rotten. He inserted these wires inside the semicircular canals, and what you see here is that the two ampulated ends come together in what we know as the common crus. And I'm going to be showing you this in a later dissection. If we look at it from a lateral perspective, which is really important, and that's usually the job of the ENT, but I think it's also more important, it's even more important for us neurosurgeons to understand what the ENT, what the neurotologists are doing when they're operating with us. The spine of Henle, which is always pointing towards the mastoid antrum, which is one of the mastoid cells which is overdeveloped, so it's very big. And once you identify the mastoid antrum, then you know where the lateral canal is, so you know where the seventh nerve is running. Because the most important thing when you're doing a mastoidectomy is to not damage the seventh nerve. Most of the neurosurgeons think of seventh nerve as, you know, posterior fossa all the way to the meatus. But there's much more to facial nerve than just that trajectory. And when you think about facial nerve, and you have a patient with facial palsy, you really should think about the entire course of facial nerve, not just its sternal segment. You should also think about the meatal segment. You should think about the labyrinthine tympanic and even the extracranial segment. Those are also very relevant. That's also very relevant information, which you should always keep in mind. So once we've drilled out the mastoid, this is called the McEwen's triangle, what you're drilling here, and it's about all the way to the asterion, tip of the mastoid, and adjacent to spine of Henle, you can reliably identify the chorda tympani, and if you drill out the middle ear, then you will come on the incus, malleus, and the labyrinth. And once you drill out the labyrinth, you're going to actually be exposing the posterior fossa dura from laterally, which has its advantages in certain cases. But what you should always remember is if you do this in a patient and you open the canals, because of the air which will be entering, the patient will be losing hearing. So you should only do this in a patient which has already lost hearing beyond repair on one side. So the indications to do this are not very common. So it's not translabyrinthine approach is not something which we'd be using very often. If we look at the middle ear again, then you see the malleus, the promontory, chorda tympani running here, oval window where the stapes sets, and if you look at this all from a lateral perspective, then you see the labyrinth, and there's a really interesting trick here which can always help you reliably identify the tympanic segment of the seventh, so of the facial, because the incus, the short process of the incus, always points to the facial nerve. This is really important, because once you see the short process of the incus, you always know where the facial nerve is running in its tympanic segment, and you also know that it's also running on the inferior side of the lateral semicircular canal. But if you're not sure and you reliably identify the incus, then and you look at the short process, you'll always know where you are. This is the common crus, which is the back end of the superior and up end of the posterior semicircular canal. Also, something which you should remember once drilling in this area is the sigmoid sinus, the superior petrosal sinus, and the bony labyrinth form together what we call Trautmann's triangle, which is really important because it's not only during surgery an important landmark, but it's also a way of abscesses and other infections to spread to the posterior fossa. So it's also something in cholesteatoma or in other pathologies of the middle of the ear. It's always something that you should keep in mind, that this is a weak spot which can allow infections to spread, abscesses to the posterior fossa, which is obviously something which you should always keep in mind. I really like this dissection here because this is opening the meatus from the middle fossa. And what you can see here is the 10 edge, and the tentorium is actually ending here in two ligaments, what we call the anterior and the posterior petroclinoid folds. So two dural folds, which are usually very, very thick, and you can see one here in the one's by the posterior clinoid, the other one is obviously in the anterior clinoid, and what you also see is the ganglion of Gasser in P2 and P3. The greater superior petrosal nerve, which is also a very important landmark once you're operating in this area. And if you drill, you see this 30-degree angle which I'm talking about. Once you drill inside, then you can expose the cochlear nerve, superior vestibular, inferior, and also the seventh. From the greater superior petrosal nerve is running backwards towards the geniculate ganglion, and then from the geniculate ganglion the facial nerve forms a genu, and it's running further across the labyrinth and the tympanic segment. So geniculate ganglion is very important, and it's also important to remember this once you're peeling the dura from lateral to medial when you're doing a middle skull-based approach. Once you've identified the middle meningeal artery, you should be very careful because GSPN is the next structure which you'll be identifying after foramen ovale. So you need to leave a sheet of dura on the GSPN and then continue with your dissection. And you can very easily go underneath it and then pull too hard, and you can actually damage the geniculate ganglion with dire consequences for your patient, because they can develop a facial palsy. And that's a really bad complication, which many patients can even lead to suicide or other problems because of extreme facial deformity, which occurs as a result of damaging the facial nerve. The really complete palsy is not so oftenly encountered. It's usually when you're actually cutting the facial nerve, or you've damaged it irreparably with your petrosal or with something else during surgery. But even a House-Brackman 3, which is halfway into a complete palsy, is still very damaging for the looks of the patient, and it's really it has a psychological enormous impact. If you open it up completely, so if you drill the entire middle fossa in order to look inside the inferior temporal, infratemporal fossa, you can see the mandibular condyle, the lateral pterygoid muscle, medial, and the temporal muscle, and you can also see V3 with all its branches, and the pterygoid plexus, which is a plexus of veins which is bleeding usually very hard. You can also see the maxillary artery, and this is how the idea of an IMAX to middle cerebral artery bypass actually came to life, because if you drill this anteromedial triangle, then you can usually most reliably find the maxillary artery. However, it's really difficult to drill and to expose this area. It's usually quite challenging, and that's why probably the IMAX bypass isn't so widely used as people would have expected when it first came out and was first published. So if we look at this again, and the Gasserian ganglion has been set aside, so we see here a very well defined pituolingual ligament, and we're also seeing the deep petrosal nerve, which is coming together with the greater superior petrosal nerve to form the Vidian nerve, which is running in the Vidian canal between V2 and V3, and which is also a very important landmark if you're doing an anterior skull-base approach through the nose. What we also see is the geniculate ganglion, and in this dissection they only let the cochlear and the facial nerve stand inside the internal acoustic meatus. Once again, the skull base, this portion of the bone, which is sometimes dehiscent, is called the tegment tympani, and it's also a region of bone which can allow for infections to spread to the brain itself, or abscesses, or sometimes the area where CSF fistulas can happen in surgery. Especially if you damage the structure around here, then you can get a CSF fistula. So you should also always take a lot of care in order to close the tegment tympani. And then we also see the superior petrosal sinus and the posterior fossa dura lining the roof of the internal acoustic meatus. So I just wanted to show you this because what people say is that, and what also has been demonstrated in the literature, is that between the greater superior petrosal nerve and the internal acoustic meatus, you have about a 60-degree angle, and this is called the cochlear angle. So this angle here is the one where the cochlea resides, and this area here is the area where the vestibule resides. So these are a couple of anatomic, very important landmarks which you should remember. And look at this dissection. It's also a very beautiful dissection from Fukushima's atlas. You see the cervical carotid coming here inside the carotid canal and getting into the Petrous carotid, and you see here the cochlea. This is GSPN, which has been cut and which went to the geniculate ganglion. This is the middle ear with incus and malleus. Tensor tympani coming here above Eustachian 2, and the three semicircular canals with the common cruise here. So this is really a very beautiful dissection. You see the internal acoustic meatus, dissected skull base. And once again, the Vidian canal, this is foramen rotundum with the V2 running to the pterygopalatine fossa, and the Vidian canal, which houses the Vidian nerve, after the deep petrosal and the GSPN have come together. And this is what you get if you're drilling from laterally, parallel to the external acoustic meatus. You're coming in this area here and exposing the labyrinth. And if you drill this labyrinth out, or sometimes even drill a cochlea, then you can get to this region and to the side of the internal acoustic meatus. And sometimes certain acoustic neuromas or other big meningiomas sometimes have indications to be approached this way, but only if the patient has lost total hearing without any possibility of improvement. This is also a dissection which has been done by Fukushima in his atlas, and you can see here the fundus of the meatus, the cochlea, and the facial nerve. It's a very beautiful anatomy. And look at this one. This is V3, petrosal and GSPN going to Vidian above the Petrous carotid. So this is something very beautiful. So what we see here is we're getting ready to do combined petrosectomy, and a combined petrosectomy is actually not drilling out the whole petrous bone, but is a way of dealing with very large petroclival meningiomas, which extend from the sphenoid, petrous apex, and all the way to the posterior fossa. We're going to be talking about that in a minute. Look at this dissection. This is actually opening up the internal acoustic meatus at the fundus. You see the transverse crest and the vertical crest, Mills bar. You see the nerves, superior and inferior vestibular, and this is the vestibule which has been opened here. And if you drill further, you see the semicircular canals, and then you can you know a little bit of the anatomy, which leads to a combined petrosal approach. So this is what I want to show really quick here, what Fukushima's philosophy about the combined petrosal approach is. So about 6-7 centimeters from the tragus, and about 2 centimeters from the asterion, root of zygoma, and this is about this is the skin incision. Always do a vascularized flap. You see here squamosal, the temporal muscle, and then you can proceed with the first part. And the first part of this approach is doing a mastoidectomy all the way to the sigmoid sinus and exposing the labyrinth. Because you want to preserve hearing, the labyrinth will not be open, so you're not going to be doing a translab. So once again, asterion, McEwen's triangle, spine of Henle here, squamosal, and once you've drilled that out, you can see the semicircular canals once again, and then what you want to do is you're going to be opening with your craniotomy about 2 centimeters in order to get inside the posterior fossa and mobilize this sinus. You need to do a burr hole here about 2 centimeters from the sigmoid sinus, about 5 centimeters from root of zygoma to the squama, and about 1 centimeter about the squamosal suture. And then once you've opened this up entirely, you're going to have to be drilling these bony spicula, which you find at the level of the root of zygoma and the floor of middle fossa. In order to not forget where we are, this is the superior semicircular canal. This is the external auditory canal. You see here the apex of the petrous bone, which is being uncovered, and it's being drilled out. Once you've drilled that out, you're going to be coming into this part, and then you can open the dura. You have to pay careful attention to the superior petrous sinus, which is running in the petrous ridge, and then you can, once you've opened the dura, you're going to be exposing this beautiful view of the posterior fossa. Here's the trochlear nerve, fourth nerve, which is running in the tentorial edge, and then you can divide the tentorium. And Professor Fukushima has a very beautiful article on dividing the tentorium in what he calls a shark fin-shaped opening inside the tentorium. And then once you've done that, you see this is like a shark fin, like this. Then you come on this area here, which is called, and which is also housed by, you see this part here, this is called the trigeminal fibrous ring. We also have fibrous rings at the carotid and the vertebral artery, but we also have them here. You see it's encased here before the cave of Meckel, and this is the trigeminal entry root zone at the level of the pons. So once you've reached here, you can open the dura retrolabyrinthine, so at the posterior side of the labyrinth, and then you can see here foramen jugulare, the jugular foramen with the 9th nerve, 10 and 11, the ICA, which is looping across these nerves, 7 and 8, going to the porus of the meatus, and then you can open the trigeminal fibrous ring further with 4 coming this way, and really make your way to the cavernous sinus, and at the end really expose this enormously beautiful anatomy. Just imagine that you have a really big sphenopetrocleidomeningioma, which is covering this entire area here. It would be almost, I dare say, impossible to do it by just a simple Cavazzi approach or just a simple posterior fossa approach. You'd have to probably remove half of the cerebellum in order to reach this. This is a really beautiful exposure, which you can use for very large petrocleidomengiomas for young people, and especially they give you this plane of dissection here between the pons and the brainstem and the tumor itself, because sometimes the arachnoid plane is not apparent. But if you're really a good neurosurgeon and you're really a good skull-based surgeon, you should be doing this surgery. Then you don't really, you're not only relying on this. You can really perform the dissection from above, and while preserving all these very important nervous structures here, and try to keep especially the perforators of the brainstem intact, because the perforators of the brainstem are really problematic, and sometimes you get lucky, but most of the time one perforator, due to their distribution, one perforator will make hemiplegic. I thank you all, and I hope you're still awake and could follow my presentation.
Victor, thank you very much. Excellent presentation and superb photos and illustrations. We've watched a lot of hangouts in the neurosurgery area. It's amazing how much you guys have to know anatomy. I mean, it's so crucial that you know every nook and cranny, every little piece, every little, more than any specialty I've seen. You really have to know anatomy. And I think that's probably the first area in medical school where people figure out they're going into neurosurgery. When you first look at anatomy, did you immediately, you must have loved it, right?
Yeah, well, it's really funny. I did love anatomy. I always have, and from the very beginning and up to now, it's really the most beautiful thing I can imagine. For me, it's art. Just looking inside, looking at these pictures, looking and then doing a dissection. That's art for me. That's like looking at a painting, and that's like microsurgery, very fine movements, very and that's also when I see an operation, it's like art, you know, when you see the finesse. But I really loved it instantly. But I have to say, I wasn't I wasn't immediately drawn to neurosurgery as in, you know, I want to be a neurosurgeon. No, I just loved all of the anatomy, all of the anatomy of the human body, like everything.
Right.
And
not just the brain.
No, but then what I did is, you know, I learned it all, you know, leg, you know, doesn't matter. I learned it all because I loved it, and then I decided, you know, I upon doing it very profoundly, I understood, okay, neuroanatomy is the one for me, and then I knew it, and then I knew, because if you don't love this anatomy, you won't be able to know it and to understand it as you should. It's really, yeah. There's really no discussion about that.
Yes.
Yeah, obviously you're a big student of Dr. Breton.
Yeah.
Obviously,
Yeah.
and I you know, before I ran into Slav and you, I didn't know. Of course, I'm not a neurosurgeon, but I didn't know who Dr. Breton was until I discovered that when after talking. As a matter of fact, there was a neurosurgeon this morning from Canada that said, "Oh, of course I use Dr. Breton." You know, it's like, why do you ask? I mean, he's the authoritative anatomist for neuroanatomy. He's the authority that everyone looks at.
Yeah. And that's, you know, Rotan. You can't escape his name in neurosurgery. I mean, that's, you know, that's a given. That's not something you can escape. But he's actually from Gainesville. So no, he's not from Gainesville, but he used to be a professor in Florida, you know, in Gainesville, all his life, and he went to his lab there. So that's you know, that's close to home, right, John?
Very good.
Yes,
okay, Slaven, go ahead.
I wanted to comment, if you can hear me well, that what said is great. It was the same for me when I discovered anatomy and started to go into its depths and revealing all the beauty and lore behind it. Then I was fascinating with the new areas of the body. And when I discovered neuroanatomy, I really found something beyond my imagination. I was fascinated by all 3 dimensions that go into play here. So then I discovered Professor Roten's, and it really depicted all the things that I imagined. I didn't know that there's a picture that says this, what you can find out in the books, and I hope I was satisfied with all the pictures that we in our anatomy atlas. So I started to look for some resources, and that was the thing that made me love and to be fascinated by neurosurgery. So this was also a great picture. I think it really resembled all the beauty and fascination of the anatomical relationships with the master.
You know, I don't know. Are you having a hard time understanding the question, Victor?
No, I understand it perfectly, and I commend Slaven for you know, for being like this and for discovering Rotan at a relatively young age. I mean, you know, Rotan's book, The Millennium, you know, it was actually first and foremost, it was a Millennium addendum to neurosurgery. So, you know, the journal Neurosurgery, they had an addendum in which they said, you know, just pick the most beautiful anatomy, the most relevant, and just put it all together in one. And then they took all of that information from 2 separate Millennium editions, and then they put it together in a book, and that's the Rotan book. But if you want to go even deeper than that, then you really need to read, and I actually encourage everybody to read all 250 anatomical articles which Rotan has written. Because if you really want to go deep in this anatomy, then you need to read all of Rotan's 250 papers. Because, you know, the atlas is obviously beautiful, it's a work of art, but it's not everything. If you want to really know and feel the anatomy, you have to, 1, read all the articles, which were the base of what he wrote there, and then you should also read the other classics, Fukushima, especially Dolenz, etc. And then you have to do the dissections yourself, because the only anatomy which you will really understand in your head is the anatomy which you're dissecting alone in the lab.
Right.
That's the real anatomy you're going to remember.
Oh, okay. Well, you know, I'm probably like a lot of medical students that didn't go into neurology or neurosurgery. It was difficult for me to understand the nervous system, the anatomy of the nervous system. And I began with a text by Sidman and Sidman. It was a program text. So I don't know if you know about that book. Did you use that book at all?
Yeah, I in my first year I came across it and I found it a really good book. I mean,
It helped me a lot. It helped me a lot.
It's really helpful, and it really sketches, you know, the important information which you need to know in the beginning, and then you can, you know, you can go deeper if you want to.
Right.
But it's, you know, it's really not everybody's going to go into neuro, and it's not bad. I mean,
it's an excellent introduction to get a basic understanding of decussations and things like that. I was just I couldn't get it reading, but I had to read a good program text.
Let me tell you something. This is really funny. I actually ask everybody, but you know, there's no answer up to this point. Why? And this is really interesting. Why does the corticospinal tract, so the pyramidal tract which connects the cortex to the spinal cord, and so that's the way you control movement. Why does it decussate? Why does it have to? You know, why does the left side control the right side? And
that's a difficult concept to.
Well, it's also no. Well, it's not only a difficult concept. It's also something that we don't have an answer to.
Oh, really?
No.
Oh, okay.
Why is that? Why did that happen in the evolution? Why does the left-hand side have to control the right-hand side?
Right.
Yeah. Well, you give me a. I know. I'm gonna give. You know. I'm gonna give a really great Rotterdam dinner for somebody who's gonna tell me. You know, you get invited me here, and somebody is gonna tell me why the left side controls the right side, and why in the evolution that had to happen.
Well, Victor, I guess we have to answer that in your next hangout.
That's good.
Okay, thank you very much, Victor.